Yes, sir.
Yeah. And from UP, and is a board member of the Indian Academy of Pediatrics, a very well-known personality. And thank you, sir, for acceding to our demand that you should chair this session. And as far as Gaurav is concerned, his name says it all. For me, he is a Gaurav of my amongst my students, and is the lead of cellular therapy, transplantation, and trained in immunological disorders and their transplant. He's at Apollo Hospital in Delhi, one of the young Turks who has really delivered the goods and has made me proud of him. Thank you, Gaurav, for
Thank you so much.
accepting to moderate this session. I request you to take over the session now.
And Dr. Anupam, good evening from my side. Dr. Lalit here.
Lalit, sorry, I didn't notice that you had joined.
No problem, no problem. And
A few
warm
words
welcome.
from you, sir.
Sorry for the delay. Actually, I was busy in the OPD. Welcome, Dr. Ghanshyam, Dr. Srinivasan. Sir, as always, he's been attached with Central IAP and Delhi IAP now. And Gaurav, we are really proud of the fact that you are from our star. And Dr. Srinivasan, sir, welcome, sir. And Dr. Ghanshyam is our AV member from Central IAP. Welcome,
Thank you,
sir.
sir. Thank you, sir.
Please start the
So
proceedings.
let me introduce the speaker of today, Dr. Deepti Suri. She is Professor of Pediatrics, Allergy Immunology, Advanced Pediatric Center, PGI Chandigarh, and she is having experience Commonwealth Medical Fellowship Immunology and Bone Marrow Transplantation at Great North Children's Hospital, Newcastle, United Kingdom. She is having many experience. And over to moderator, please start. She will speak about the common immunodeficiencies. Severe combined immunodeficiency.
Yeah, thank you, Dr. Ghanshyam, and thank you, sir, for this generous introduction. I mean, we just try to carry forward the legacy which you have created. So I'm still not sure we'll be able to reach there, but yes, we are making a genuine effort. So as far as Dr. Deepti goes, we share a common sort of connect, and we both have been trained at Newcastle upon Tyne. So some of you might be aware that's one of the center of excellence for immunological diseases, and especially transplants for immunological diseases across the world. So the team is phenomenal, and the understanding of the subject, overall immunology, and how to sort of modify your transplant practices based on those underlying immunological disorders. So the kind of understanding which you have there is just phenomenal. So that's our common connect, and as highlighted by Dr. Ghanshyam, Dr. Deepti has enormous experience in immunology here, and then subsequently she has been trained at Newcastle upon Tyne. So she'll be taking us through common immunodeficiencies with a focus on severe combined immunodeficiency. Over to you, Dr. Deepti. Dr. Deepti, you're muted, so you'll have to unmute, please. Dr. Deepti, you'll have to unmute. Dr. Deepti, you'll have to unmute, sorry. Dr. Deepti, you'll have to unmute, shut up, unmute. No problem, no problem. You log in again. I'll just continue in the meantime. Just sure. Okay, so will you log in from another system? ठीक है. Sure, no problem. No problem, no problem, no problem. Thank you. So sorry, actually just received a call from Dr. Deepti. So something has gone wrong with the system. So she'll try and log in from a different system.
Gaurav, in the meantime,
Yes,
why
sir.
don't you talk about immunodeficiency in general and how it is encompassing a
Yeah.
whole lot of
So
branches in
basically, I
four,
think
5 minutes?
Yeah, I think that's something. This is something which is very, very pertinent. So all of us, like Dr. Lalit is there, Sir is already there. So I mean, as a fraternity, pediatric hematology, oncology, and now I think we should club it together, and that's what we always do: pediatric hematology, oncology, and immunology. So rest of the pediatric specialty have grown immensely and sort of have evolved into a separate chapter. But as far as we talk about immunology, something, I mean, it's still not there. Last, I think 2 weeks back, it was International sort of Immunodeficiency Day, but none of us, or hardly few of us, were aware about it. And we see a number of cases. I mean, in past 4 or 5 months, I would have seen around 5 or 6 cases who have come to us in a pathetic condition. I mean, even if you want to do something for those kids, you want to take them up for transplant, somehow they are in such a poor shape that we are not able to do anything, and we have lost actually 2 or 3 of them. Whereas 2 or 3 who are in a relatively better shape, we could transplant them, but that's the state of affairs with the majority of patients. And unlike other diseases of hematology, oncology, these are the diseases which are sort of, I mean, life-threatening disease, and the intervention has to be done within 3 months. For example, skid. The typical There's a stark difference in the outcomes if we can take up the patient up for transplant within 3 months of birth, or within 3 months of diagnosis. I would say birth, not diagnosis, because in our country they might be diagnosed quite late or not even diagnosed. So if they are taken up for transplant within 3 months of diagnosis, then the outcomes, of irrespective of what kind of transplant we do, the outcomes are almost 80 to 90%. Vis-a-vis patients whom we take up for transplant after 3 months of birth, because somehow they develop one or other form of infection, they develop some viral infection or bacterial infection, and that drastically reduces the success rate of transplant. So that's something which all the sort of leading figures in pediatrics and pediatric hemato-oncology, I would request you that, sir, we need to focus now on immunology, because that is something which is lagging. If we say that the burden of the disease is less, I don't believe in that, because with so much of marriages within the communities, the burden of immunological diseases is quite high, and there's no reason to believe that it will be less in India as compared to rest of the world. But unfortunately, there's no robust registry, so we don't know the exact incidence. Dr. Deepti might throw some light on the data which they have gathered at PGI Chandigarh, but unfortunately, that will be just a single center data and not a sort of holistic representation across the disease burden across the country. So that's my humble request. Most of these diseases are treatable and treatable very nicely, provided the intervention is done on time. So that's the crux with the immunological disease. So Dr. Deepti is back. So please, over to you, Dr. Deepti.
Sorry, I am really sorry for those technical glitches which happen exactly on the point when you don't want them to happen. But thank you, IAP Delhi, Dr. Anupam Sachdev, Dr. Lalit, and Dr. Gaurav for the kind introduction. And I would, are my slides visible now?
Yeah.
So, so today we will talk about a very special immunological disorder, as Dr. Gaurav was saying, rather under-recognized because we don't think about this disorder very often. So I'll be taking you across severe combined immune deficiency and the way it presents, the current concepts and how things are changing across the world and where we are, and especially the data from PGI Chandigarh. So primary immune deficiency disorders, which are now called as human inborn errors of immunity. And we all know that the International Union of Immunological Societies Expert Committee brings about an update on human inborn errors of immunity almost every annually or almost alternate years, and they give us insights about the new diseases that are being recognized. According to the IUIS classification, severe combined immune deficiency is the first category, that is combined immune deficiencies affecting cellular and humoral immunity. Now, for the sake of residents, I also want you to look at the second group that is also called as combined immune deficiencies with syndromic features. And here, Dijot syndrome and other immune deficiencies, which also affect both cellular and humoral immunity, are included, but they are not classified as SCID. And we'll discuss about this issue in further slides. Now, SCID is a medical emergency, and recognition, diagnosis, as well as treatment is of utmost importance, because in absence of definitive treatment, most children die in the first year of life. Now, the definitive treatment, of course, is in the form of bone marrow transplantation, as Dr. Gaurav was talking to you about. Now, before I go into the details of SCID, I would take you across certain immunological concepts that are important to understand this heterogeneous group of disorders. It is a diverse group, including approximately nearly 20 genes now, which are characterized, and it is characterized by profound impairment in T cell development and or function. They share a common phenotype. That means the patient has low number of autologous T lymphocytes with deficient numbers or a variable number or a function of B and NK cells. What is important is that there is a low number of autologous, that is patient's own T lymphocytes, but there may be a variable function of B and NK cells. Now, this is important because we all know that B lymphocytes cannot function without the T lymphocytes. So the B cell function is consistently impaired due to poor helper T cell activity. Now, this predisposes the patient to severe risk of severe infections and life-threatening infections. Now, the other concept is that this immune deficiency can sometimes be so profound that patients are incapable of rejecting maternal T cells that cross the placenta. While the baby is being formed, a significant exchange of cellular component happens at the placental level, and these essentially the maternal T cells are actually removed from the circulation. However, if there is a profound T cell deficiency, these which are mature T cells, they would cross the placenta and reach and would then home the bone marrow, and the patient may have a functional, not a mature T cells in their circulations. Now, this is important because clinically you can recognize these cells in this child's circulation, and they are called as transplacental maternally engrafted or TME cells. Now, what are the different types of SCIDs? SCIDs can be typical SCID, atypical or leaky SCID, and the Omen syndrome. The other way of putting this would be SCID with very few or undetectable autologous T cells, but they can also have transplacentally the TME T cells. The SCIDs with decreased number of T cells and no TME cells, and the Omen phenotype, which we will talk about later. But this phenotype classically is characterized by autoreactive or hyperinflammatory T cells and no TME cells. The third concept is that there are mutations. That means SCID is a genetic disorder, and these mutations occur in several genes whose products are crucial for development of both T and B cell and may affect the NK cell function. So before we go into the details about clinical presentation, I'll just take you across the development of T cells in the human body. So the first progenitor cell, that is the lymphoid stem cell, from the bone marrow has to get committed either to the B cell lineage or the T cell lineage. If they get committed to the T cell lineage, they have to go to the thymus to develop what is called as the T cell receptors, and then only they egress out of the thymus, and then they can go to the secondary lymphoid organs. Now, the genes that are affected in SCID can be from the ones which are responsible for from the egress from the bone marrow to the thymus, and from the thymus, within the thymus, and from the thymus to a mature either CD4 or a CD8 lymphocyte. So in the thymus, what is important to note is that it moves in, it interacts with the thymic epithelium, and what reaches is the double negative stage. From double negative stage, it moves across the thymic epithelium, keeps interacting with various genes and products, and then finally gets converted to CD4 or a mature CD8 T lymphocyte. Now, in the thymus, there are stages in which there happens a process called as a VDJ recombination, and this recombination helps in development of the CD4 or a CD8 T cell. So from the double negative stage, it moves to the double positive stage, and then to a single positive, either a CD4 or a CD8. Now, the T cell receptor gene arrangement happens in the thymus. In the thymus also happens an important, thymus is an important checkpoint. That means it will preferentially delete the cells that cannot recognize the MHC. It will also delete the cells which are likely to be functionally inactive, and it will also delete the cells that are unable to differentiate between the self-antigen and the foreign antigen. So these are essentially the important selection stages that also happens in the thymus. A positive selection, that means if they are functionally good. If they fail to recognize MHC, they will die because of apoptosis. Or if they are strongly reacting with self-antigens, then again they will be dying because of apoptosis. Now, what happens is from the double negative stage, it is only 2% of thymocytes that are successfully able to become either a CD4 or a CD8 T cell. So this is what is happening in the thymus. And then you realize that there are multiple genes that are important in this conversion from double negative stage 1, 2, 3, 4 to a double positive. And each gene, variant in each gene or a mutation in all such genes will result in what is called as SCID. So this is how the concept of SCID and the multiple genes is important. Now, how does it? And most of these patients would then present in early infancy because they do not have functional CD4 or a CD8 T cell. Now, there are certain genes that are very important. That is the RAG, which is the recombinase gene, which is important for the VDJ recombination, important from conversion of double negative stage 2 to double negative stage 3 and 4. We also have the other genes, which in addition to affecting the T cells, also affects the NK cells, that is the common gamma chain, as well as the JAK2. And of course, we have the ADA2, and I'll show you by examples how we can identify or think about these genes as one of the candidate genes in a child in whom we are suspecting SCID. So flow cytometry is a very robust way of identifying what cells are getting affected and what may be the underlying candidate gene. So we all start with T negative. That means the T cells are depleted. Then we look at the B cell positivity and whether they have NK cell or absent NK cells. And so we classify SCIDs as T negative, B positive, NK negative, or T negative, B positive, NK positive, or a T negative, B negative, NK negative SCID, and T negative, B negative, and NK positive SCID. And then we have the candidate genes depending upon the level at which they affect. Now, in addition to flow cytometry, there is also another important concept which has affected the understanding about SCID, and that is the newborn screening program, which is based on the detection of T cell receptor excision circles. Now, what are T cell receptor excision circles? I told you that during the process of development, there is within the thymus, a VDJ recombination, that is development of the VDJ recombination is occurring. And while the VDJ recombination is occurring, there is a lot of splicing as well as combination of various genes that is happening to develop the alpha and beta chains. As a process of this splicing and joining, a byproduct is formed, and that is in the form of a T cell receptor excision circle. And these T cell receptor excision circles then are egressed into the peripheral circulation and can be detected CR. And this recognition of TREX is used for as a newborn screening method for SCID. So, and it is being well established. It started in Wisconsin in US. Now, the entire 50 states of US, most of the European countries, Japan, are doing SCID screening, newborn screening based on the TREC assay. Now, what has also helped because of the newborn screening is that we can estimate SCID incidence, and it is now estimated to be 1 in 58,000 live births. So if you can think about it, in India, where the number of live births per day is so high, the incidence of babies born with SCID is going to be much higher. And especially in states where there is higher consanguinity. In certain Indian states, the consanguinity can be as high as 40%. So we all know about this famous picture. And this is David Better. And he was called as the bubble boy. And he survived. He was kept in the bubble for good more than 13 years, and subsequently received a transplant from his sister. But during those days, screening was not very effective, and the methodology was not very effective, and he died of EBV-related lymphoproliferative malignancy later on after transplant. But David could survive in his bubble for free of infection for such a long time. But what is important here is that in addition to David, I want you to look at this doctor, Dr. William Shearer. He was his primary physician at Texas Children's Hospital, and this picture is from 1979. Now, Dr. William Shearer's contribution to SCID is in the form of establishing the diagnostic criteria for SCID, for leaky skin, as well as the Omen syndrome. He was the first person to kind of attempt to establish the diagnostic criteria, which were published in 2014. So the diagnostic criteria at that point were based on the T cell numbers, whether there were naive versus he also metric test, that is naive versus memory T cells, T cell proliferation responses to PHA. That means even if your numbers are okay, but the function can be assessed by proliferative responses. And also one could look for the transplacentally acquired maternal engraftment of T cells. So these, the T cell number, looking at the naive T cells, then looking at the function of T cells and the TME cells. So, as science always progresses, with the genomic studies, things had to change. Sometimes this change can add on to confusion. So the recent insights to the diagnostic criteria came from the newborn screening, from the genetic sequencing results, and the treatment outcomes. And the latest paper by the Primary Immune Deficiency Treatment Consortium, PIDTC, gives the current definition of severe combined immune deficiency in the year 2022. And they dedicated this paper actually to Dr. William Scherer. These diagnostic criteria were then subjected to validation, and multiple sites have validated these diagnostic criteria. So what are these diagnostic criteria? The first statement that they say is the term SCID is reserved for patients with a defect intrinsic to hematopoietic stem cells that prevent their differentiation into phenotypically and functionally mature T cells. So there is a problem, intrinsic defect in differentiation to a mature T cell. And in addition, they can have B and T NK cell differentiation of functional abnormalities, as said before. Now, in addition to that, there is also a concept that has been introduced, and that is that definitive therapy requires establishment of an hematopoietic stem cell population intrinsically capable of generating T cells, either by allogenic hematopoietic stem cell transplantation or an autologous cell transplantation with corrected genes. Now, why have they introduced this as a concept? That is because some patients may have abnormalities in the T cell number. They may have similar presentation in terms of lymphocyte phenotype and clinical phenotype, are not SCID because they cannot be cured by HSCT, but in fact, they need a thymic transplant for their cure. That means the problem lies in the thymic stromal cell development. And if you look at the first figure that I had actually shown, in that figure, the interaction between thymic epithelium is so important for the progression from double negative to single positive stage. Now, these non-SCIDs are the DiGeorge syndrome and some pathogenic variants in FOXN1, FOXN3, or the TBX1. So there are certain non-SCID, and they are the ones which in IUIS classification are combined disorders, but they are not SCIDs. Hence, the treatment component has been added to the definition. Now, looking at the differences, now I'll spend a minute on this particular slide because this is what the diagnostic criteria of SCID is all about. So if you look at the 2022 definition, for diagnosis of a typical SCID, one would need fulfillment of criteria 1 and 2 or 1 and 3. Now, what is criteria 1? That means you have to demonstrate very low T cells. This is In 2004, the low T cell number was something like 300, but in 2022 definition, this is 50 cells. That means there is a 6-fold decrease in threshold value of absolute T cell count. Now, in addition to that, you have to demonstrate a pathogenic gene variant. That is, if you fulfill both the criteria, you can diagnose a typical SCID. If you do not find a pathogenic gene variant, you can still diagnose SCID if you show a low T cell number. But in addition to that, you would have to demonstrate either undetectable TREX or less than 20% of CD4 positive T cells on the naive cells. So that means you have to demonstrate 20%, less than 20% CD4 positive naive T cells. One can even diagnose only if one is able to demonstrate the TME cells. In addition to that, one must always rule out HIV infection, the DiGeorge syndrome, MHC class 2 and class 3 deficiencies, and certain metabolic conditions that imitate SCID. Now, in any of such confusing tables, it's actually the footnote that is most important. And here, if I must read the footnote says that T cell subset determination should be repeated at least once, with the second test taken as the criteria value. And if a patient has been identified to have a pathogenic variant, the interval between the two tests must be at least 1 week. However, if you are unable to demonstrate the pathogenic variant, the T cell number must remain low for at least 8 weeks to qualify as typical SCID due to the potential of spontaneous improvement with a shorter interval only if the urgent HSCT is required before 8 weeks. So this is what it is, that if we do not find a pathogenic variant, then one can wait for recovery of T cell number, which can happen spontaneously in some patients up to 8 weeks. So there is no PHA in the current definition if you have a pathogenic variant. Now, on the other hand, the leaky SCID needs 1, 2, and 4. And in the leaky SCID, that means either there are low T cells, oligoclonal T cells, that means the maternally derived or a single cell population, or if there is low TREX and one has to demonstrate low CD4 T cells. There should be pathogenic variants. And here, when you do, in this particular patient group of leaky SCID, one can use proliferation as with PHA as one of the criteria. So I think I'll explain all this again. And there is another definition from Omen syndrome, and we'll take this definition when we go to the case discussions. Now, T cell lymphopenia or low TREX. So T cell lymphopenia can happen in non-SCID conditions also. And this is when you have ataxia telangiectasia, MHC class 1 or class 2 deficiencies, Naegeli-Breakage syndrome, Down syndrome, and other chromosomal aneuploidies. We also already talked about this thymic stromal cell development, that is CHARGE, and the DiGeorge syndrome. And there is a condition called as idiopathic T cell lymphopenia, as well as the secondary T cell lymphopenia in patients who have advanced HIV infection, especially if there's a maternal high viral load, chylous effusions, gastrointestinal and cardiac malformations, maternal immunosuppressive medication, and in prematurity. So after the newborn screening, low T cell counts were seen not only in SCIDs, but secondary causes, prematurity, idiopathic T cell lymphopenia, and certain syndromes. TREX will, however, be normal if the variants happen after the VDJ recombination. So classically in ZAP20 deficient 70, in which the double positive T cells have already been formed, is a a situation characterized by low CD8 T cells, and in this particular deficiency, you may have normal TREX. One can even have normal TREX if there is MHC class 2 deficiency or ADA's delay. So this is when you are confirming a SCID, but most of the time in clinical practice, we talk when we are suspecting SCID. So for suspicion, low CD4, low CD3 T cell count, less than 20% of naive CD4 T cells, plus abnormal TREX, which is not available to us, but we have the family history of SCID and we have recurrent and or opportunistic infections. So if you have recurrent and opportunistic infections, one can strongly suspect SCID if there is less than 0.3, that is less than 300 CD3 T cells, and looking at the naive CD4, which is characterized by CD3 positive, CD4 positive, CD45 RAs as a surface marker. You can also suspect SCID if in a firstborn child, but in this case, you have to demonstrate both low T cells as well as the low naive CD4 T cells. And of course, one can suspect SCID if we are talking of Omen syndrome, in which one has to demonstrate the more than 80% of memory cells, that is CD45 and RO positive cells, in addition to rash, eosinophilia, or lymphadenopathy. So among the genetics, we have the most common is the IL-2-RG, the RAG, ADA, and IL-7 receptor as the most common SCIDs in the in population. Now, moving on from hardcore immunology to something which is much simpler to understand. So how do patients with SCID present? Most babies with SCID are healthy at birth. They acquire infection postnatally. Majority of the patients will present within the first 6 months of age. The presentation is early infancy. They have failure to thrive. They can have persistent diarrhea, recurrent or severe pneumonias, and of course, they can develop candidial infection in the form of thrush, which quite often is not the presenting manifestation, but recognized when we proactively examine the patients. In addition to that, they have serious opportunistic infections. So PCP pneumonia, we give BCG to all our children, so disseminated BCG infection, but more important would be the viral infections in the form of CMV, herpes, and fungal infections. SCIDs can, especially hypomorphic ones, the hypomorphic RAG ones, can have a milder phenotype and they can persist and present later in life. But at that point of time, they present with autoimmunity, granulomas, lymphomas, EBV proliferative disorders, and a progressive decline in immunoglobulin production. I'll not be talking about these milder phenotypes, but we'll restrict ourselves to the pediatric presentation. There is no going back from history and physical examination, looking for tonsils, hepatosplenomegaly, and lymphadenopathy, taking a detailed family history, looking at the prematurity, maternal drug intakes, which is also very important when we are evaluating a patient with lymphopenia. Then you look at the quantitative defects in the form of complete blood count. One must order serum immunoglobulins, including IgE, especially if you are thinking about Omen syndrome. Go ahead and do a flow cytometry to look for TB and NK cells. We've already talked about, but we also look for naive and memory T cells, and we can do some protein estimations for specific test. If we do not find, we've already talked about there is an importance in looking at T cell function by PHA. And lastly is the genetic confirmation. Probably these days, with the availability of molecular sequencing, what is happening is that you just look at the history and physical examination and order the last test first, and the reversal of the step-by-step approach is happening. Now let's look at the cases. 5-month-old child with 3rd-degree consanguineous marriage presents to the pediatric emergency with cough and rapid breathing. A possibility of a community-acquired pneumonia is kept. However, the elder sibling had died at 4 months of age. She's extremely tachypneic. She has a saturation of 82%. Nothing abnormal was noted. However, when we look at the complete blood count, one must get into the habit of counting the absolute neutrophil count and the absolute lymphocyte count. Now, if you calculate the absolute lymphocyte count, apparently it appears like sepsis and a polymorphic response, but look at the lymphocytes. The lymphocytes are so low. Mother's HIV is negative, and the gastric lavage actually yields a PJP. Now, here is a patient in whose a chest X-ray should be looked for the thymic shadow, and there is no thymic shadow, which can also be confirmed on an ultrasound examination. So severe pneumonia with PCP, infantile SIP death, absent thymus, lymphopenia, HIV excluded. What one suspects is a severe combined immune deficiency. And if we look at the suspected SCID situation, we find that the patient does have lymphopenia. We will have to look at the naive T cells, but there is a family history suggestive, and there is an opportunistic infections in this particular child. So we go ahead and do the lymphocyte subsets, and we realize that the upper panel is the control panel. And if you look at the CD3 here, I'm not sure if I have a pointer. So in the second panel, in the patient's panel, if you look at the difference, one would realize that there is no CD3 T cells, and the B cells, however, are present. So this patient actually has a T negative, B positive, and an NK negative SCID. Now, going back, the resident had also ordered an immunoglobulin profile for this patient, and they said the child does not have a hypogamma like what you expect in SCID. So this is not actually SCID. But one must be careful in interpreting serum immunoglobulin levels, because IgG here is normal, but this IgG is maternally transmitted, and the child is only 3 months of age. So refrain from really interpreting serum immunoglobulins or ruling in or ruling out of SCID on the basis of immunoglobulin profile. And as I showed in my previous slides, there is no mention of immunoglobulin in the diagnostic criteria. So if we look at the T negative, B positive, NK negative SCID, we have JAK3 and IL2RG. Now, this is a female child. IL2RG is an X-linked disorder, while JAK3 is an autosomal recessive disorder. So most likely the candidate in here is JAK3, and mutation was detected in JAK3. Now, on the other hand, this is another child who has BCG site ulceration, oral thrush, a low absolute lymphocyte count, a very strong X-linked family history, again a T negative, B positive, B for boy, and boys are B positive. So that's how I remember B positive SCIDs are common gamma chain. And X-linked, so here what we expect is a common gamma chain or IL2RG. And then we can even estimate the common gamma chain by flow cytometry by doing a CD132 assay, which is a marker for common gamma chain, and then confirmed by genetic sequencing. Now, common gamma chain is the one that you can see here in orange, or orange, and this is a interleukin-2 receptor subunit, which is important for for at least 6 different interleukins act through common gamma chain and subsequently stimulate the JAK-STAT pathways, and hence problems in common gamma chain can result in severe combined immune deficiency. Now, when we aspirated from the cutaneous sites, the cutaneous abscesses which the patient was having, it was actually laden with AFP and it was confirmed to be a BCG. So disseminated BCGiosis is a very important presentation in patients with severe combined immune deficiency. A child being followed up for late onset neonatal sepsis. Lymphopenia again missed, and this child was in the newborn nursery for 4 months, for 4 weeks from the first day of life, and they were struggling with multiple antibiotics, antifungals. But what was very clear was the profound lymphopenia. And look at the absolute count. CD3 is 246, CD19 is 27, CD56 is only 23. Now, when you have such profound lymphopenia, which is affecting all the 3 cells, 3, 19, and 56, you can even get a simple clue from the chest X-ray and look at the inferior scapular angle squaring, which can be seen in patients with ADS kids. And patients with ADS kids have profound lymphopenia, and they are T negative, B negative, NK negative kids. You can even do the ADA enzyme assays to look for the levels in the patient, and you can see that the ADA levels were extremely low in this particular child, and both the mother and the father were carriers of different mutations. One was a novel mutation in the mother. The father had a previously reported mutation, and subsequently even the functional testing was performed in this particular child. Now, why does ADA lead to profound lymphopenia? Is because it causes toxic metabolite generation. These toxic metabolites can occasionally be detected in the blood and urine by tandem mass spec also. And ADA is a emergency in which one can actually do enzyme replacement, and I'll talk about that, as well as gene therapy. So this is a child who was being followed up as with jaundice and interstitial pneumonia, hepatosplenomegaly, and there was low platelet count. Residents were chasing the platelet count, thinking of Wiskott-Aldrich syndrome. But when we looked at the profile, with persistent thrombocytopenia, CMV infection was thought about. Now, whenever we talk about CMV infection, one must always bring about immune deficiency disorders. And this patient, this may be the most important presenting manifestation in most of the patients. So there is an absolute lymphopenia, and this patient actually has a T negative, B negative, NK positive skin and a mutation in RAG2. Now, when you have sometimes similar presentation in the form of torch with microcephaly and developmental delay can also be SCIDs. And these are specifically patients with NHEJ1 mutations, and microcephaly and developmental delay should also make us think sometimes, not necessarily infections, but infection with microcephaly, one must think about underlying SCID as a possibility. Lastly, I'll take you to the 5th case, which is so typical of being referred from dermatology as erythroderma. And here what we note is that this is a 6-week-old baby who was exclusively breastfed but developed persistent ear discharge from 7th day of life. There was this erythematous rash, erythroderma, alopecia, absent eyebrows, hepatosplenomegaly, and a BCG site ulceration, as well as fever and respiratory distress. Now, when we actually look at lymphocyte count here, the lymphocyte count is actually 70% lymphocytes and not lymphopenic. But the clue comes here from the eosinophilia. The presence of eosinophilia is helpful, though the absolute lymphocyte count is high. And this is the feature in which you do not find lymphopenia, but eosinophilia and a high IgE levels. So one must order for immunoglobulin E levels in patients, in these patients in whom one is suspecting Omenn syndrome. The T lymphocytes are oligoclonal and they are high. B lymphocytes are low and NK cells were present. So in this particular patient in whom we are suspecting Omenn syndrome, one must also order what is known as the memory compartment, looking at the memory compartment and looking at the activation markers on CD lymphocytes. So CD45RA on CD3 positive was low, but CD45RO, that is the memory compartment, is very high, and they highly express the HLA-DR, which is the activation marker. So this patient actually is a T negative, B negative, NK positive SCID with Omenn phenotype. So suspecting SCID or Omenn is when you have more than 80% of CD45RO cells. The CD3 cells may be more than the 0.3 into 10 to the power 9 value. You can have generalized skin rash, eosinophilia, or lymphadenopathy, or organomegaly. Now, for confirmation of diagnosis, you need all the 4 criteria. That is, the memory phenotype is high. You can have pathogenic variant, you can have generalized rash, eosinophilia, or either of the two, eosinophilia, elevated IgE, abnormal TREX, lymphadenopathy, hepatosplenomegaly, or oligoclonal T cells. This is the flow cytometry to look at CD45RA and RO, that is the naive and the memory compartment, and the activation in the form of HLA-DR. So what happens in Omenn syndrome? There is a clonal T cell infiltration of skin and intestine, liver, spleen, and these patients present with diarrhea, rash, exfoliative erythroderma, lymphadenopathy, and hepatosplenomegaly. And I've already talked about the other things. So this is the classical flow cytometry of a detailed flow cytometry of a Omenn phenotype. So can lymphocyte counts be normal in patients with SCID? Yes, they can be normal if there's an Omenn syndrome, or if you have maternally engrafted T cells, or if there is a clonal proliferation of T cells, or if the patient has an MHC class 1 or class 2 deficiencies. So how can you look at the maternally engrafted T cells? You can actually estimate the naive T cells, the HLA-DR, which I've already, and one can even do a FISH or a VNTR analysis for the maternally engrafted cells. And one can even do a CD4-CD8 ratio or a T cell proliferation. Now, the T cell proliferation is done by PHA, and it can be easily done by flow cytometry. One of the important differentials, which is not a SCID, is the Dye-George syndrome. And if you're suspecting Dye-George syndrome, what one must order is the MLPA to look for the chromosomal deletion. But identifying the subtle dysmorphism is important. Patients with Dye-George syndrome have thymic defect. Their immune deficiency slowly improves with time. So it is very important that we recognize and differentiate Dye-George syndrome from SCID. So this is how the entire diagnostic armamentarium works. And we must look at the clinical profile, the CD4-CD8 ratio, naive memory T cells that I've already stressed upon, and the T cell proliferation assay. But do you need a genetic diagnosis before transplant? Though it is not necessary always, but it is important because DNA repair defects have an increased susceptibility to alkylating agents. And hence, if you're strongly suspecting a DNA repair defect, then one must wait for the molecular confirmation because the pre-medication is going to be affected. The alkylating agents that we are going to use for conditioning is important. It will be important aspect, especially in DNA repair defects. So how do we go about treatment? So the treatment is essentially multi-pronged. One has to treat for acute infection, initiate them on chemoprophylaxis, give them immunoglobulin replacement, and prepare them for transplant as a definitive therapy. One would also use targeted therapies and gene therapy occasionally, which is not readily available in a country yet. So acute infection, use empiric broad spectrum antibiotics, very long durations, have a low threshold for antifungals, antivirals. I've already talked about CMV, and one has to often resort to giving a BCG chemoprophylaxis in the form of either rifampicin, INH, and levofloxacin and ethambutol. So immunoglobulin replacements has to be done high dose to bring the child out, as well as subsequently replacement till the child is transplanted. So while giving, an important point that needs to be remembered is that while giving blood products to these patients, always insist on irradiated and leukodepleted blood products, because this will prevent the GVHD as well as alloimmunization, and CMV should be kept in mind because CMV negative blood should be given to CMV negative patients. Now, hematopoietic stem cell transplantation is best successful if the diagnosis is if it is performed within the first 4 months of life. So it is curative, and we know that the first successful non-twin bone marrow transplantation was performed by Dr. Robert Good for a patient with SCID, and the 5-month-old SCID child actually, they had lost 11 male members of his extended family, and this Dr. Good led the team that corrected his fatal condition with bone marrow transplantation, and the donor was his 8-year-old sister. Transplant is curative and is the standard of care for many PIDs, but it is a medical emergency in patients with SCID. So the challenges are that you usually do not have a match-related donor in the family, which gives the best results. So we have to resort to either a MUD or a TCR or a haplotransplant or a cord blood transplant. And we all know the disadvantages and advantages of the donor source. Conditioning is an issue in patients with SCID because these patients have very low number of cells, and quite often a reduced intensity conditioning is to be used in these patients. And I told you the conditioning regimen is often guided by the DNA, by the presence of DNA, whether the patient has a DNA repair defect or not. So first, a transplant for PID was performed in 1998 at Vellore for a child with Viscott. But at PGI, we did a first transplant for a child with SCID. Challenges, we know that when we see these patients, they already have disseminated BCG, CMV, and fungal infections. And there is a problem in identifying a suitable donor for the particular children. And of course, then subsequently we have problems with GVHD and rejection. So this was a paper by Dr. Revati Raj on outcomes of transplantations in all PID patients. And she had, in this particular paper, she had talked about SCID, 55 children with SCID. And she had, it was a multicentric study, and you can see Dr. Gaurav as one of the contributor in this paper. And they used PBSCs mostly in near. And what they realized that, again, patients with SCID did not have a very good outcome because of the fact that they had already developed infections by the time they were transplanted. Enzyme replacement can happen for ADS SCID, and this molecule is now being marketed in India. If we identify patients with ADS SCID, you can actually consider enzyme replacement therapy for these patients. Gene therapy.
I think somehow Dr. Deepti Suri has been disconnected.
Yeah.
I'll try to contact her. I'll just try to contact her. Just give me a minute.
Dr. Gaurav, meanwhile, while she connects her, I want to, as a general pediatrician, how common is SCID in India, and how much, as a general pediatrician, what is the message for us?
So, sir, as rightly as highlighted by Dr. Deepti, so you can see that the incidence of SCID is in across the globe is like 1 in 58,000, which is sort of not it is a rare disease, but not such a rare disease. So, if you look at the number of childbirths in our country and try to extrapolate that, so the number of SCID patients will be significant. The problem is that majority of these patients, unfortunately, are not diagnosed. They are just treated as neonatal sepsis, and we lose them just before the diagnosis. Now, the key to identifying such patients is a very careful observation, and as Dr. Deepti has highlighted, there are a number of cases. There are some very significant clinical markers which we should keep in mind. And the foremost thing is that if you have a infection, so common infections with sort of uncommon severity or common infections at uncommon sites. So I think these are the three key clinical markers which a pediatrician should always look at. And when you club it with a careful interpretation of CBC report, where you can very classically see lymphopenia, I strongly believe that we'll be able to pick up almost 90% of the cases of severe combined immunodeficiency. Now, this is such a I would say it's such a easy disorder. Like for malignancies, we say Hodgkin's lymphoma is like a cakewalk if we pick the patient up at the right time, or Wilms tumor for that matter. Similarly, if a SCID patient is picked up at the right time, the outcomes are phenomenal. And as she highlighted, it is close to 92%, which is actually the case. If we get the patient at right point of time, the outcomes are more than 90% irrespective of the donor. And in a number of these patients, just because they do not have T cell, so T cell is classically absent. The patient might have B cell, they might have NK cell depending on the different phenotypes, but T cell will definitely be absent. Now, this is an advantage when we talk about transplants, because the chances of graft failure comes down to almost negligible. The chances of graft versus host disease, if there is no maternal contamination, so if it's not a Omen's phenotype, then the chances, there are practically no T cells or very low T cells. So the chances of graft versus host disease is also very less. So in that case, irrespective of the donor, whether we have a full match donor or a half match.
So yeah, Dr. Deepti has joined back. Dr. Kaira again. Dr. Deepti, can you hear us?
Oh, yeah. Can you hear me?
Yes, we can hear you.
So irrespective, so these are, I'm sorry for that in the last few slides. So irrespective of whether we can help the child, the index child, I would request that one must offer prenatal diagnosis. And if you are in doubt while managing these patients, please keep a EDTA sample, which can be the most precious sample for the particular family, which can be subjected to genetic testing, and subsequently a prenatal testing can be offered to the patients. We are still far away from newborn screening for PIDs in our country because of the cost involved and screening program at a national level. So Dr. Vignesh, my faculty colleague, had actually collected the SCID data from various centers, and they collected data of 277 children with SCID, and you can see there was a fair representation of in this group. And if you look carefully at the microbiological profile, we can see funguses, we can see viruses, we can see cryptococcosis, as well aspergillosis, PCP, as well as the presenting manifestations in the form of BCG site ulcerations, otitis, as well as pneumonia, which obviously would be the first one. Now at PGI, since the time that we have started focusing on primary immune deficiencies and development and the establishment of the ICMR Center for Advanced Research, we have the increase in awareness has led to increase in referrals as well as increase in recognition of these disorders. So what the mind, what the eyes see, only what the mind knows. So was I still muted?
No, we can hear you now.
Please
We can
off
hear
your
you, but
video.
we cannot see your presentation. We can hear you, but we cannot see your presentation.
Can you see my presentation now?
No.
Is it
Not seeing.
So Dr. Deepti, is it fine if
visible
you
now?
can summarize it?
Not yet.
Yeah,
We are not able to. It's just rolling around. Started
Madam,
to share.
internet speed is the issue. You can off your video.
Can Dr. Deepti, can we summarize it?
It started raining. It started raining here, so probably the internet is not very
I
stable.
mean, can we summarize it, ma'am?
The internet it is just started raining here.
So I think, can I just hello?
Please, please, Doctor.
Yeah,
please.
so I think there are some technical issues at Dr. Deepti's side. So I mean the key points for the fellows or for the
So
students.
I'll just summarize by saying,
Right.
summarize. It's the last slide.
Ma'am, you just speak your slide. We don't have to see it. You just summarize it and
so I'm just
speak your slide.
these are the last slides. So all I can say is that with increase in awareness and recognition, we more and more children are being now transplanted. And the transplant in such patients, if you catch them clean, is easy because the chances of rejection is very limited. So these patients, identification of these patients is the problem. If we identify these patients well in time, then the outcomes can be exceptionally good. And I think with that, I'll end with the last concluding slide is not there, but I'll just end it here.
Thank you very much, ma'am. In fact, I think with IEI and STID, etc., we are at the same crossroads as we were with pediatric oncology a few years back, or about 3 decades back when I started. And the lag period, what we call as a lag period, was very, very big at that time. And now it has been reduced to quite an extent. I think we need to start a series of awareness lectures across the country to sort of bring in these patients early, clean, because once the infection is established, then everything becomes very, very, very difficult. And a fungal infection will never go away and will cause you problems during transplant also. So I think that is the key thing which we have to recognize, and in this, the role of the general pediatrician is very, very important. I mean, for example, all the IEI patients which we get we get them from the ICU. And you can't really do anything by the time they have reached the ICU. It becomes very difficult to do anything about them. Gaurav, if you have anything to add, we can.
I think you have rightly pointed out, sir. So basically, the key thing is the diagnosis, and if you actually look at these patients in a very very close, I mean, if you observe them closely, a number of patients can be diagnosed because they do give us quite a number of signs which suggest that this is not the usual infection and this is something more. So the early diagnosis is the key. And once we diagnose these patients early and take them up for transplant clean, as I've highlighted earlier also, the transplant outcomes are phenomenal. I mean, for other diseases, if we talk about for thalassemia, for sickle, for leukemias, for aplastic anemias, our outcomes are even better than the Western world. So why not for primary immunodeficiency? The only thing is that these patients come to us at a late point of time, and that is what leads to poorer outcomes in these patients. And actually, these are very safe to transplant. In a number of patients, we don't even, if they are not in a good shape, we don't even need to give them chemotherapy. So we can just infuse the cells and bring up some T cells, make them clinically well by putting them on IVIG for some time, and then we can do a sequential second transplant with a little bit of conditioning when they are in a relatively better clinical shape. So if you plan these patients nicely, the outcomes are phenomenal. So as rightly said by Dr. Anupam sir, that we need to have some system in place so that we improve our sort of diagnostic yield for these patients and subsequently refer them to the centers. So I wanted to ask Dr. Deepti, so the number of patients whom you have picked up, how many of them have actually undergone a transplant? So you said that it's sort of a center of excellence, I mean now PGI, and definitely you can see from the chart that the number of patients picked up are quite high. Now, what makes sense is that how many of these patients were actually
She has left again. She has left again. So it's not that common that I work there. So it's not that every child with immunodeficiency.
No. Now, there are almost 100, 120 patients which they have diagnosed. So I wanted to ask that how many of them have been transplanted, because that's what
many. I cannot count them, but many. And the good part about PGI is, and specifically about rheumatology and immunology, even if you go at this time in the ward, 9:15 or 10:15, even the consultants would be taking the round, and all the residents would be on the round, and with peace of mind, cool, and taking the histories and examining the child. So that is the level I've seen there. So that I can tell you, but how many are transplanted? That's a tough question for me to answer. So I think Dr. Deepti has joined again. Maybe she can answer. Dr. Deepti, there's a question for you. Dr. Gaurav, can you just say that again?
Yeah. So Dr. Deepti, I wanted to check. It was inquisitive to know that out of the patients who have been diagnosed in past, say, 5 to 10 years, how many of them have actually been transplanted?
So at our center, we've been able to perform only for 6 patients at PGI Chandigarh.
Yeah.
But in that 200, six kid patients out of the total patients, primary immune deficiency patients. But in that 277 patients that Dr. Vignesh had collected, among those patients, these number of patients who actually, this was from a varied center, so there 23 of them had received transplant. So we are actually very far away from transplant in these patients, and with 75% mortality rate. So
I think so. If I put it this way, less than 5% of the patients who were actually diagnosed underwent a transplant.
Yes,
Yeah.
could be taken up for
First of all,
transplant.
first challenge is that the diagnosis is not there. That is what we need to work on, so that because the number of patients who are picked up, the number is at least 20 times higher. The actual number of these patients is 20 times higher, looking at the incidence of this disease globally. Secondly, once they are diagnosed, then the next big challenge is which which is I mean even worse, that we are not able to take them up for transplant. So that system needs to be put in place, that once a patient is diagnosed, the patient needs to go in for transplant, putting in whatever resources required, public, private partnerships and whatever, so that they are transplanted soon and
as early as
in
possible.
the best quality of life. Yeah.
Right. So in the interest of the time, Dr. Deepti, can we summarize? And Dr. Gaurav, can you just say some words of the wisdom? And Dr. Deepti, ma'am, there is no words I can describe you. I was just mentioning when you were not online that even at this time, 9:30 or maybe 10:30, I have seen the allergy immunology unit working like normal 10 a.m. So all faculties on round, all residents on round, and with peace, not like hematology, oncology, shouting and howling. With peace,
No. You have just
no,
Dr. Mukesh.
Just a tweet.
That's the best compliment, Dr. Mukesh, that I have actually heard.
So let me be true.
That's
So that's the
yeah,
truth.
so
So she may have seen us, and we would have been like, "Oh shit, she had heard us." So but
Thank you.
that's so. Anyhow, can you summarize it, ma'am?
So just the carry home is that all sepsis, think when you actually diagnose children to have sepsis, why did they develop sepsis? Ask questions, uh, do a little bit of more calculations, be a little more proactive in taking your histories and physical examinations. A little bit of flow cytometry will help us in diagnosing. And if we diagnose these patients early, we can really give the family a boon by giving them a normal child. We have seen patients struggling with multiple sibling deaths, and it's just a little bit of sensitivity on our part. Diagnosing SCID is not difficult. That's my carry home. But only if we think about it.
So true. So, Dr. Lalit Mendiratna sir, would you like to say something?
No, I have heard a lot about SCID today. I think the carry home message was the best I could get, and the madam has literally given the insight into how the presentations are and what are the exclusion criteria. Basically, you have to remember them also. You keep them on the table also. So that is one of the things. And always your mind should be open, whenever you suspect anything unusual, as Dr. Gaurav has just said before. Always keep it in mind, then only your eyes will be able to make a diagnosis. So just on one corner, always keep this thing that this could be one of the differential diagnoses. This could be the cause associated with the unrelevant infections or the severe infections. And just one more thing, what is the problem in relation to the early screening newborn? That kit is not available, the track kit, or it cannot exclude all the immunodeficiencies. Just a one word, basically. Anyone can say.
So I think TREC is something which is, so whenever we start a newborn screening program on a larger basis, it has to have that cost and benefit analysis. So I remember when it was initiated in Europe, it was like extensive discussion for a year or two, looking at the incidence of the disease based on the solid or robust registry which they have. And after that, after 2 to 3 years, they could convince the government that looking at the incidents which they could present to the government authorities, it's something which is mandatory. If we talk about doing it in routine here, like with 227 cases or say 300 or 500 cases picked up in the entire live births, the births which happen, we have no justification to say that this is something which makes sense financially. Okay. So that's where the problem lies. TREC is otherwise a very useful test for screening, but I think it has to be a cost-effective screening. Then only we can use it for larger group of newborns.
How much it costs? Suppose there is a suspected family death in early infancy. You can be done.
So it's a PCR-based test.
This is a screening test. So basically, I would say in our context, if we do a TREC analysis, it would cost roughly around, say, around 3,000 to 4,000. It should not pick up. It is a flow-based test, so it should not cost more than that. But I think if you have a strong family history, then as Dr. Deepti highlighted, if you go into the details of the family history, the time of deaths, the possible infections, if there are any medical records available, then rather than going to TREC, which is a screening test, we have this aegis based IE inborn errors of immunity sort of panel available, which can pick up almost, I would say 97-98% of the cases. So
Right.
then it would be sensible or more meaningful to opt for that particular test in case we have a strong family history.
Right. Thank you. Thank you. Thank you very much. Mukesh, you can wind up now, I think.
Sir, Dr. Ghansham, would you like to say something?
Sir.
I want to ask one question, madam. What
Please,
is
please.
life
Yes.
expectancy if we diagnose early and transplant?
So if you transplant them well, they they stay well all through. It is cured. They are cured most. So it's the success rate reported in patients who've been transplanted before 3.5 months is to the tune of 95% in Western centers. So it's a very high success, and it's, as Dr. Gaurav
So
already said.
it will be more than 95% if you refer to PGI.
Yes.
I'm sure, Dr.
So
Ghansham.
early diagnosis and treatment. It is
So at PGI, we've not lost a skid baby. We've not lost a skid baby who was transplanted. All the patients who were transplanted are doing well. We've lost a child with HLH, but not with skid
good, ma'am.
during transplant.
Thank you, ma'am, for excellent talk and learned something new.
I'm
Great.
really sorry for the technical glitch. And one more little point. One more little thing that I wanted to tell for the sake of general pediatricians is that if you have a strong feeling about the patients to the previous child to have skid, then probably counsel the parents that in the next child they should not get the BCG and the vaccination. So they can prevent BCG vaccination in the subsequent child, because BCG related complications are a big problem. So that is also something that we have to revisit about, especially when you have multiple sibling deaths in a family. Don't be in a hurry to give BCG.
Right. So, message well taken, ma'am, and appreciated. Anupam sir, would you like to say anything? I think Anupam sir is not there with us. So, I can vouch. I don't know about others, but I worked in PGI, and there is no other better center than PGI in terms of immunology and rheumatology than Madam Deepti's center. They work like anything. I have seen my co-XRs and co-PGs. They work like anything. We did not even work 1/10 of what they worked. So I must appreciate and I salute to them. Kudos to you, ma'am. So, any other comments, sir? Dr.
And I'm
Lalit?
sorry for the technical
No,
problems
no,
that
no issues,
happened.
ma'am. It's
No,
fine.
madam, no
It's
issue.
not your fault, ma'am. It's a technical thing. That's why you're apologizing, ma'am. It's fine. It was our pleasure to have you. So kind of you that.
Thank you.
But if you were not with us, you would have been bored, I'm sure. You would not have been
Thank
So,
you.
Dr. Lalit, can we close?
Thank you,
Is
sir.
it fine?
Yes.
Yes,
Thank you very
please
much.
close.
Thank you, Dr. Ghansham, Suri, and Dr. Very nice.
So,
Sir.
Dr.
Thank you.
Ghansham, thank you very much. Dr. Gaurav, thank you. Dr. Priti ma'am, thank you very much.
Thank
So
you.
we can
Thank
close
Thank
the
you,
session.
Dr. Mukesh.
Night,
Thank you,
everyone.
Lalit sir.
Thank you.
Thank you.
Thank you,
Bye.
Priti ma'am.
Thank you, sir. Okay.
Okay, good night.